Hello, Dr. Dombo. How are you?
Good, Rachel. How are you doing?
Good. I'm okay. I jumped on a few minutes early because I wanted to sort of take the time to revisit what we had talked about in brief our first live and be able to take advantage of the time now. I let everyone know you're a hard stop at 30 minutes. You have patients to see. So I wanted to kind of get us started with the conversation at hand. I let people know that there were questions that came in. I know you have those questions. So we can start wherever you like. I know you and I had talked about revisiting the sort of mental health challenges that come up in perimenopause, but if you would maybe just lay the groundwork for us, start us where you want, and
Sure.
get into it wherever you like.
I can just kind of start with like brief with our definition, because I think that's always a place to
Sure.
start, right? Whereas we know at this point that menopause is the 12 months with having no period. Once you've gone 12 months with no period, we can definitely say that you are now in menopause. And perimenopause, and what I love is peri means around, right? So I have my humidifier going.
I was just going to say, there's a fire somewhere.
Now,
What is happening?
for my dry eyes. So when I
Yes,
breathe,
which we heard about the first
yeah.
time we spoke, right?
So
Was
always,
your sort of lesser known symptom.
yeah, that was a symptom that kind of took me by surprise. So I usually, whenever I know that I'm on a screen and, my blinking it could be impacted, I always like have a humidifier with me so that I can make sure that the air is adequately hydrated so that my tears, the tear production, it is not compromised.
Okay, great.
Fire.
Good to know. Yeah.
Again, perimenopause, the word means around, and it means, around menopause. So it's the gradual, the natural period leading to menopause. And so it's the natural and gradual period that occurs as the ovaries stop functioning. And a lot of people are like, okay, well, how do I know I'm in perimenopause? Well, it's one of two. You can have one of two things occur for you during that time. You can have some menstrual irregularities, like you notice that your periods start to change is one. You can have that, or some of the symptoms that are associated with menopause. And I think part of the reason why there's so much confusion around, is this perimenopause? Is this mental? It's because there's so many things that we don't know, and a lot of research that hasn't been done yet, that we're now starting to really realize and recognize.
Right.
And I think that the medical culture is now starting to catch up, right,
Sure.
with that.
Mm-hmm.
So it's so important as a patient to be, aware and knowledgeable and know what some of these symptoms could be. So I think, one of the things that we had talked about was pretty much how it presented for me. Like, I did talk about, the dry eye situation that I had. But I think for me, when it came to what drove me to looking at starting hormone replacement therapy, were the mood symptoms that I started to experience. And as you know, I'm an OBGYN, work 24-hour shifts, and I've always said to myself and told other people I could sleep on a rock, right? I don't need a soft bed or a comfortable bed because I work 24-hour shifts, and therefore, the need to sleep is always there, and I could sleep anywhere. But I think what gradually started to happen with me is that I started to notice that even after these 24-hour shifts, I couldn't sleep while I was on shift. And if I had a patient who was pushing for delivery, that I had time to sleep in between, I couldn't fall asleep. And it led to a huge impact in my well-being. I also noticed that I started to have these symptoms where, let's say I had a conflict with a friend, it would take me into a spiral. I just couldn't, I felt like hope, and I was like, why is this happening? This is something that normally I'd be able to kind of bounce back from, but I just started to notice that I couldn't cope. I started to feel like I could only do one thing over the weekend. I was so fatigued. And just my mood, the anxiety, the depression really started to have an impact, on my life, right? And, we can talk about anxiety and depression, but let's break it down. Like crying spells, crying a lot, and then feeling like, why the heck am I crying?
Yeah.
But you just really, and then feeling hopeless, that feeling of hopelessness, feeling worthless, losing interest in some of the things that I used to want to do. And then you obviously want to withdraw, right? And so what I ended up doing was I said, okay, well, I really, um, you know, I was taking care of women who are going through perimenopause, being able to, counsel them and take care of them, but, with hormone replacement. But for some reason, I just had a block when it came to myself, right? And so made an appointment with a psychiatrist. It took a few weeks because I was really concerned. The nurses would call me at the hospital, and I'd forget. I'd forget that they called me about something. And so it was impacting my workspace. Made an appointment with a psychiatrist, and I remember having a conversation with my sister a week before that, and I was taking care of her and prescribing her hormones, right, for her perimenopausal symptoms. And she just basically said to me, Kudzai, could this be hormonal, what you're going through? And so I ended up, 4 days before the appointment with the psychiatrist, I started an estradiol patch. And within 4 days, I was feeling significantly better. And so when I still kept the appointment. I went to the appointment, but I found that I actually ended up educating him, about what perimenopause and the symptoms of hormone deficiency, estrogen deficiency are, and that I didn't really need anything from him, right? And it was a bit frustrating because he knew nothing, but I actually appreciated the fact that he was willing to say, I don't know.
Yeah, yeah, yeah.
Don't. And he was also willing and able to say, look, you know what, I'm not going to do anything at the moment, but let's circle back in 3 months because you may be feeling differently and you may really need, something else. And gratefully, like very gratefully, I felt significantly better within a short period of time. But I'm telling you, the symptoms that I had, you feel like you just don't, like you get to a point where you're just like, I don't want to do anything. I don't want to face anything. I don't want to face anybody. And it was very, very distressing to me. And it was more distressing because I felt like I couldn't really communicate it to a lot of like my colleagues, that this is what was going on. But I knew that something was really wrong enough to say, okay, I need to, get help somehow, some way. And again, it just made me more invigorated in wanting to help other women, who go through this.
Dr. Dombo, I'm listening to the story, and the first thing I want to say is thank you for sharing it, because um, it the numbers of us women out here who are not physicians, who are just doing any number of other things, who are impacted in ways like this is so great. And to number one, hear from a doctor who is educated about this season of life, understands the hormonal piece, and still is sharing that, yes, this is something I went through and it really impacted my day to day. And it wasn't just your relationships, it was also your work environment, is enormously helpful for the rest of us out here to kind of first of all, be seen, be heard, know
Yeah.
that we're not alone, but certainly to recognize the ways in which hormonal deficiency, estrogen deficiency can impact us. And this week, it's been so loud, the sort of the dialogue around estrogen receptors being everywhere in our bodies, right, including our brains. And we can sort of parse out these conversations around mental health stuff to speak specifically to that. But we know, sort of looking at the big picture, that the decline of estrogen impacts every system, every organ, every part of us internally and externally. And so thank you for amplifying that and highlighting your part of the story, your experience. It's enormously helpful. And I think encouraging also that there is help,
Yeah.
there are solutions, and that it's interesting that, you had a conversation with your sister, put on a patch, went to your doctor's appointment. We can talk another time about how, what it means to a doctor to go or anyone, a patient to go and sort of educate a physician. That's happening now. All of us are kind of experiencing that in live time. That he was receptive is awesome. But really, that you were able to get help within days is very critical, I think, for people to know that there are solutions out there for you. Um,
Absolutely.
Go on. I'm sorry. I don't know how much you wanted to get further
Okay.
into that part.
For me, right, I did not really know the connection between estrogen and like our
Yeah.
brain and time, right? I knew, like, I was really new to starting, I was prescribing it for, typical symptoms, but I was also new to seeing that it helped. But what I understood from just after a lot of reading was that how, like, the feel good hormones, like your serotonin and your epinephrine, estrogen is responsible for stabilizing those hormones, right?
Mm-hmm.
So those brain chemicals, and so, let's say you are on an SSRI already and you're feeling those symptoms, it
Mm-hmm.
may not necessarily mean that you need a higher dose of an SSRI, but it may just mean that you need the
Right.
estradiol in
Right.
conjunction to help, the stabilization. Because what happens is those fluctuations in estrogen are what can destabilize that whole process. And it could just mean adding the estradiol. Or for someone, it may mean an SSRI. I'm not saying that estrogen is the only,
Sure.
but it's just being aware, that the two work so closely together. It's not something that the medical community is, especially, when you go to a psychiatrist, they're going to be aware of that. And again, I just would say, you know, we all know what it feels like to be dismissed. I wasn't dismissed by the psychiatrist, but at least, it's just going to take time before people can actually, that this is what
Yeah.
happens.
Yeah.
Body.
Thank you for that. And I think again, just appreciating, just hearing from you, hearing from each other, that this is how this sort of season can begin. It can begin in ways that you don't necessarily associate with something hormonal when in fact it really is, and it's largely impactful. Whether it's anxiety or depression, honestly just sort of feeling like hopelessness or loss of interest, and followed by withdrawal from sort of your day to day, is a very, very big deal, and a lot of women are walking around feeling that way, and certainly not, particularly if they're under 40, in which cases they could certainly be beginning perimenopause, but that's the furthest thing from their mind. So again, thank you for that. Um, Dr. Dombo, there were a few other things, and I'm just being conscious of your time, that I wanted to get into with you as much as we can. One, and I guess it's sort of it's a nice segue. Forgetfulness, brain fog, ADHD symptoms, feeling sort of delayed in response. Can you talk about those?
Yes, 100%. So I think 2/3 of women in perimenopause will experience those things, right? Your memory, issues with your memory. You're like, I
Yeah.
can't remember that name, right? Forgetfulness. I mean, I left a purse at a restaurant, right? Didn't realize it until the next morning when I needed my purse to walk out the door.
Ugh.
And so, I missed a flight, so those kinds of things you forget, where you have brain fog, you feel like I have ADHD. Oh my gosh, I'm just slower in my process of thinking what's going on. I'm just feeling a lot of confusion. I'm having difficulty concentrating on things. Those are all very, very, normal symptoms of estrogen, either fluctuations or decline. And it just has been shown, even Dr. Lisa Mosconi has shown that, estrogen plays a critical role in how the brain functions, not only just normal function, but also like the different parts of the brain communicate with each other.
Right.
So if the brain's not communicating with each other, the different parts of the brain aren't communicating with each other, you're going to have those symptoms. And so, I've heard so many patients say, it's like, it's on the tip of my tongue. I just can't remember the
Sure.
name. I And so it just could be a sign of, declining or fluctuating, estrogen levels. But it's also important, right, to rule out other factors, right? So it's important to talk with a physician, because could it be a side effect of other medication? Could it be from depression itself, head trauma, stress? There are all these things that cause it. But, when you think about declining estrogen levels or fluctuating estrogen levels, it's a bunch of symptoms. that are all like, that's where we kind of think, okay, if this is perimenopause causing this, there's that. It could be in isolation, but it also could be accompanied by, well.
So I think, and you've said this before, that many physicians do, that hormones can be a first line of defense, but that doesn't mean that you shouldn't kind of reach out or pull those other threads a little further and follow up with a physician in person about what might be going on.
Exactly, because we also want to piece together the whole history, right? We also want to look at, okay, what medications are you on? Have you started on certain medications that could contribute to this? Are you dealing with a lot of stress in your life, right? Are you like, or could there be drug or alcohol abuse as well that's going on? Are there vitamin
Right.
deficiencies that could be leading to this? So it's really good to have a very comprehensive look, but also know that, okay, you know, in that differential diagnosis could be declining estradiol levels, which again is something that I don't think included up until recently.
Yeah, no, for sure. Um, I'm moving on to some of the other topics that came up. Postnasal drip and snoring. This is a not so fun one. What is going on?
I know, right? There's all these symptoms that I was like, oh my goodness, what in the, what in the world? Who would have thought,
Yeah.
right? So there is a connection between, the release of histamines in our system and hormone levels. So let's say you have like these really wildly fluctuating hormone levels in perimenopause, that can cause an overfiring of histamine, right? During the perimenopausal phase. And that histamine gives you allergy-like symptoms. So if you start to notice that you experience eczema, for example, if you're having nasal congestion, if you're having like rat wheezing, symptoms of like like allergy type symptoms, that could be really because you have these wild fluctuations in estrogen during perimenopause that are leading to the overfiring of histamine. And the other thing is progesterone itself. Lower levels of like progesterone has been found or has been shown to stabilize mast cells, and mast cells in our bodies are responsible for histamine release. So when you have declining progesterone levels, mast cells are destabilized and you can have an over release of histamine, and that histamine in our bodies is what can relate to those symptoms.
And it's MAST cells or MASK cells?
MAST.
MAST cells. Okay, interesting. I didn't know that. I never heard that before. All right. Pre-diabetes and high cholesterol. Another thing that, women will hear very
Yeah.
often in perimenopause. Well, you're pre-diabetic, or, oh, your cholesterol's gone up a bit. What's going on there?
Yeah. So whenever you have hormonal changes like fluctuations in estrogen, so insulin is the hormone produced by the pancreas that's responsible for blood glucose, regulation. And so what happens is estrogen is responsible for that, the stable release of insulin. And so when you do not have that, like if you have fluctuating levels, of estradiol, it will impact your insulin release, and that is what stabilizes your blood glucose level. So it's really interesting because I've had some patients, I feel lightheaded, I feel dizzy sometimes. I'm just not, I don't know why I'm having this symptom. And even when you start on hormone replacement therapy or menopause hormone therapy, right, you can notice that like it takes a while for your body to stabilize to the hormone. If you have fluctuations during that time, you can feel lightheaded. Like some of those symptoms are a result of the fact that, again, estrogen has an impact on, insulin production, and that insulin production is responsible for stabilization of glucose. So when you don't have that, it can lead to prediabetes, for example.
That's insane. I mean, so the numbers of women, so removing diet for a minute, which is huge and really should not be removed. I don't mean to say that,
Yeah.
but hormone, fluctuating estrogen,
Mm-hmm.
the decline of estrogen
Yeah.
is, there is a line between that and prediabetes.
Mm-hmm.
That's huge. I mean, that's huge. That diabetes is
Yeah.
so serious. It's such a big deal that it's a really important factor. Okay, sorry.
Estradiol is protective. It's protective,
Yeah,
right?
yeah,
And that's part of the reason why when we look at, and so many people talk about like your health span, right? We're trying to we don't want to just increase your lifespan. We want to increase your health.
right.
And so when we look at things heart disease, diabetes, all those different things that can happen to us as we age. If you start estradiol during that critical time, between 10 years of your last menstrual period or before the age of 60, it really does have a protective effect. And that's why it's just something to consider if you know that you have, very strong family history of diabetes, which, I mean, every single one of my uncles had diabetes. My brother has it. It's looking at, okay, wow, considering my family history, I may be going down that road. How do I also look at my decision, to
Mm,
start, or I don't want to start, or when I want to start? Those are all things to factor in, because yeah, like prediabetes is just a sign of, okay, well, you're on a trajectory, right,
right.
path, that if there's a way that we can kind of reverse that, that would be ideal, so that you have more years where you're living a healthy life versus just, okay, you're living a life, you're on medications, and you may end up, your mobility is there, there's a way to really look at how, you know improve the quality of your life in the
Thank you
long
for that. I have heard this before. I found that kind of unpacking of it particularly enlightening. We talked about estrogen quite a bit, but this question came in about testosterone, if I might share it with you.
Let me just do the second piece to that
Oh,
previous
please.
question.
Yeah, go ahead.
Cholesterol, right? It was like the pre-diabetes, but also
Yes, apologies. Yeah,
with
please.
cholesterol too. So again, estrogen is responsible for maintaining healthy cholesterol levels. And one of the things that happens when estrogen levels start to decline is that, you look at your LDL, which is bad, the bad cholesterol, that starts to go up. Your triglycerides go up, and the HDL, which is the good cholesterol, also starts to go down. So, when you look at maintaining cholesterol as well, I think traditionally we always looked at, okay, you go on a statin or
Yeah,
you manage your diet. So, but also looking at, you know, what is the trajectory of high cholesterol? What will that lead to? We think about coronary artery disease and heart disease if, it's not well managed. And so, again, it's one of the things to consider and think about, if you look at personal history, your family history, and what are the, not just looking at today and my symptoms, but also, the long-term impact of, you know, my health.
Dr. Dombo, you just made me think. My question to you was about knowing when to start, because you've really sort of laid out and made the argument, in terms certainly, various chronic diseases, that estrogen or hormonal therapy is protective, right, to many systems and
Yeah.
organs. How do you know when to start? And I know that the pill is an option for many for a host of great reasons, including um, avoiding a pregnancy.
Yeah.
But if you're, still getting a period, you're not a year out, and you're thinking about protective measures,
Yeah.
not so much even symptomatic measures,
Yeah.
can you start?
So I think it's very person dependent, right?
Okay.
So, some majority of women start, and typically what all, the guidelines into, ACOG and some of the other associations, you're having symptoms, and that's pretty much why you start. But I do believe that it's a very individual dependent decision.
Okay.
There's shared decision making with your doctor. So I have some patients who come to me knowing that they have they've already demonstrated osteopenia. They're not
Right.
really having symptoms, but they really would like to start, and if they're having some, you offer all options, right? Because if you want to improve your bone density, there are other medications, but there's some patients who really do want to start on estradiol. And for
Right.
me, it's shared decision making with the patient. And I'm here to provide you with your options, and you move from there. So I don't think that there's necessarily a one size fits all answer to your question, but I do believe that one of the things that we're seeing from this model of shared decision making is that, patients, have a certain level of autonomy
Yes.
in decisions, as long as they're appropriately counseled. right?
Right.
As long as you appropriately counsel patient, they can figure out what's the best decision for them. So I never, obviously we all know the best time to start based on the current data, right? The current data is within 10 years of your last menstrual period. For the That's kind of what the guidelines currently go. But again, there are also nuances to every person's personal history, that may, have them wanting to start sooner,
Earlier.
or even if they.
Um, Dr. Dombo, I want to get to some of the questions that came in. I know we've got 2 minutes, so you've got like 30 seconds per question. But here's one that pertains to what we just talked about. At around 38, I found out that I had high cholesterol and prediabetes. I turned both around with adjusting my diet and exercise. Now I'm curious if I need to add HRT to help. I think you sort of just spoke to that, but if you want to wrap that up, yeah.
Yeah, I mean, again, it's one of those things where I think you need to, know the exact numbers, so I can't really speak to,
Sure.
but the fact that you were able to turn everything around with diet and exercise is huge. And that pattern of nutrition and exercise is something that you want to carry through, as one of the tools for continuing to manage that. And then, if you notice in a couple of years things start to reverse, then you can have a conversation with your, right, to see, hey, am I an appropriate candidate at this point for starting hormone? Because right now at 38, I think you are producing estrogen. You're producing
Right.
within your own body that's protective. So the need to add more, unless you're having other symptoms, may not necessarily be an absolute need. Again, I'm speaking with very limited information there.
No, that's so helpful. Thank you for that. Um, Somebody asks, if I'm prone to hormonal migraines, am I still a candidate for HRT?
100%. I mean, I don't know how old you are. I don't know other, issues about that, but specifically hormonal migraines occur when estradiol levels drop, right before you ovulate, you have a drop in estrogen, your progesterone levels start to go up. So once estradiol goes down, that can precipitate the migraine,
Right.
headache. And so having added a cushion of estrogen during that time can reduce, the migraines. We didn't get
Excellent. No, I know. That's okay. I have a really quick fibroid question.
Okay.
Um, she had a uterus. She believes estrogen caused her fibroids. She still has ovaries, although they seem dried up. I'm concerned about the estrogen. I'm 55. Anything you can offer about fibroids in 10 seconds?
At 55, your fibroids, like, you have no estrogen within your system that's going to cause the fibroids to grow. And the amount of estrogen in hormone replacement or menopause hormone therapy is such a low dose to really help with symptoms, not significant enough to really cause the regrowth of the fibroid
Okay.
time.
Okay.
I,
Dr. Dombo, I hear knocking
yeah,
behind you. You have to go. You have patience. Thank you so much. And thank you to everybody who came today. And we'll do this again. We have a webinar coming up in the fall.
sounds good. Thank
So
you.
thank you guys. Thank you so much. Bye-bye.